just past 1 o'clock our time. So welcome everybody back to TAPS for 2025. I'm Gary Lee, and I'm very honored today to have Professor Jane Shaw, who is a pulmonologist and clinical researcher from Stellenbosch University in Cape Town in South Africa, to join us to kickstart this year's TAPS series. She's going to talk about TB pleural effusion, which is a common topic, especially in Asian Pacific, where I think a lot of people logging on today are going to be at. As like before, we'll mute everybody at the moment, but if you've got any questions, please type on the chat room and we'll look at it during and after the presentation. We aim for about 15 minutes presentation, and we can have a good conversation afterwards. If you or your friends or your colleagues missed the this podcast, then it will be posted on YouTube. If you just go to YouTube and search for TAPS and pleural, then it should come up with all the previous year's recordings as well. So without further ado, I'll give the floor to Jane. Thank you very much, Jane, for doing this.
Thank you, Gary. I'm very honored to be here and to be the first one of the year. And I'm so glad that we get to talk about this topic, which is really something that I'm very interested in. And of course, we see it here all the time. You heard Gary say that I'm in South Africa, and at the moment, probably 1 in every 5 pleural aspirations that we do ends up being tuberculosis. So we have a very heavy burden of disease. And I was given the option to talk of any aspect of pleural tuberculosis, but I've chosen to focus on the diagnosis because I think it's probably the area where there's the widest variation, appropriate perhaps variation, around the world. And I'm going to show you why. But I'll start by showing you, or perhaps I'll just hang the whole kind of discussion on a case that we saw just the other day. And we can call her Nancy. She is a 28-year-old woman. She's very healthy. And we saw her because she's actually enrolled on a TB vaccine trial in our unit. And she comes from a little place called Wellington, which is about an hour outside of Cape Town. And normally she just follows up at her Wellington clinic, which is a very basic facility and only has a doctor on 1 day a week, et cetera, et cetera. And she presented to her clinic on the 17th of December with a 3-week, this is 2024, with a 3-week history of cough, fever, night sweats, and pleuritic chest pain. And they quite appropriately tested her sputum for TB. And I hope that's not too small for you to see, but the highlighted part is her Gene Expert Ultra, which was negative for TB. And so without any further tests or anything, she actually felt quite a bit better, and so she didn't go back. But she did come to us on the 17th of January just for a routine follow-up of her post-vaccination research visit, and complained on that day of a persistent pleuritic chest pain, which was worse on the left. So everything else had resolved. She wasn't coughing anymore. She had no fever. All the night sweats were gone. She was feeling fine, except that she had a little bit of pain on the left. We did an ultrasound, and you can see that on the left-hand side, she had probably on the ultrasound, a moderate-sized, uncomplicated pleural effusion. Maybe there was a little bit of a fibrinous thing waving there in the fluid, but overall, no loculations to be seen. And her chest x-rays, somewhat less impressive. You can see the little star there where the meniscus is. And so she had a pleural effusion, which we then tapped. And what I'm showing you on the left is that by Light's criteria, she had an exudate. And then on the top on the right, she had it wasn't purulent, but there was a lymphocyte predominance of 84% in the fluid. And she had a high adenosine deaminase level in the pleural fluid of 47.4. We tested it obviously for organisms. So on her conventional gram stain, there wasn't much to be seen. There was nothing on the aerobic or anaerobic growth in the culture bottles. And we did our TB tests, which is again a Gene Expert Ultra on the fluid, which was negative. And the smear was negative. And well, because this was the 17th of January, we don't have a TB culture result yet. So there she is. She's a healthy young woman with a pleural effusion, and she's got an exudate, which is lymphocyte predominant with a high ADA. And the question then is, have we proven TB? And the answer is different depending on where you are. So in South Africa, yes, this is sufficient for the case definition for a TB effusion in South Africa. Whereas somewhere like Australia, I think probably not. And just before we move on, I just have to mention, because I know some of you are burning to point this out to me. Yes, there was a very small cavity on her chest X-ray on the other side. We did retest her sputum. It was still negative. And in a situation where there is bronchoscopy available, that would definitely be a reasonable approach to diagnosis, is to chase that cavity. However, let's pretend that she is in fact sitting in her clinic in Wellington and is unable to access bronchoscopy. In fact, that clinic doesn't even have a chest X-ray. So she would just have her pleural fluid results and the clinician's belief that it might well be TB. So why do we have different case definitions or diagnostic criteria in different places in the world for pleural TB? And the answer is really very simple, which is that the prevalence is quite wildly different in different places in the world. If you look at the map from the Global TB report, you get a very clear impression of where you should be more strongly considering TB as your diagnosis for your pleural effusion, and where it's less likely and you should be pursuing other diagnoses. And if I take a few publications, and there's not a lot on this, but do some very basic mathematical calculations using the number of TB cases in total in 2022, the percentage which is reported to be pleural, and then we come out with a number of pleural TB cases overall in the whole country in 2022, you see how different that number is between South Africa and USA. So here in South Africa, we should have about 28,000 cases per year, whereas in the US, with almost 10 times our population size, we should have maybe 450. And the reason, of course, is obvious. All TB prevalence is driven by things like HIV prevalence, poverty, malnutrition, overcrowding, et cetera, et cetera, et cetera. And it's these things which determine the prevalence of pleural TB as much as they determine the prevalence of pulmonary TB. But there's another reason why we have to consider diagnosing pleural TB on a slightly looser case definition than we would consider perhaps for other infections, or at least other versions of TB as well. So in the absence of Mycobacterium tuberculosis being identified in the pleural fluid, we can still say this is pleural TB because we know that these tests don't do well in pleural fluid. And this is kind of the spectrum of pleural TB fluid results that you're likely to see. Most of the people, when you aspirate the pleural fluid, you're going to find them on the left-hand side of the spectrum, where it's predominantly a lymphocyte-driven Th1 type, Th1 CD4 helper mediated response with granulomas, etc., to a very, very porcibacillary infection, very low mycobacterial burden, if there are any at that stage at all. And then a few patients will be on the right-hand side of this spectrum, where they have a higher mycobacterial burden. The fluid is more neutrophil predominant, perhaps even, frankly, purulent, and there is ongoing pleural infection, as opposed to simply a granulomatous response to contain the antigen. And the reason why we don't get good results from our NTB tests is because most of our patients that we test are sitting on the left-hand side of that spectrum. And this is a very basic summary of what we can expect from conventional TB tests in pleural TB. So sputum culture is not a bad option, and I would suggest that we always pursue it, because sometimes there are occult quite often there are occult pulmonary lesions associated with the pleural TB, and especially in people who are living with HIV, you may find that there is a higher yield. But in the pleural fluid, a smear, which if you'll believe it, is probably still the go-to diagnostic test for large portions of Africa and even, I would say, Asia, and really almost 0% yield for that. Whereas culture is a bit higher, and so is your nucleic acid amplification test-based type of tests like your GeneXpert Ultra, which I showed you earlier. But all of these, where you see the right-hand side of that spectrum, the 63%, the 61%, that is in a very specific, the higher end of the yield is in that very small portion where there is a higher bacterial burden and also often more likely to be in people living with HIV. The nice thing about these tests, though, and the reason why we still do them, even though they don't likely yield, is that when you do find a positive, it's got a specificity of more than 98%. So finding a positive means that's definitely the answer. Now, there's a problem with the studies that reported, there's several problems, but these are the two most important, that report these data, which is that they tended to lump in together all the different types of pleural TB, empyema along with your standard lymphocyte predominant effusions, which makes how they report their results difficult to interpret. And the other thing is that, for example, studies looking at Expert Ultra, the diagnostic accuracy of Expert Ultra, they will often use culture as the gold standard. But of course, we know culture is not a very high yield investigation in this disease. And so it's a very imperfect gold standard. So that's something we always just have to keep in mind when we're interpreting information about this particular set of tests. And the same thing is true of biomarkers, except that biomarkers are very much context related when you are interpreting them. So there's a number of, I mean, there's way more than what you see in this table here, but the most commonly described pleural fluid biomarker is the adenosine deaminase, and it's the most available as well. There are very cheap kits that you can get and put into an normal, whatever machine that you have in your lab. And so here in South Africa and most of the places in the world that I have, interact with about this topic, they have ADA, and it's reliable. And of course, it has a high sensitivity and a high specificity in the right context. So there you'll see I've put that little arrow there saying that where you have a lymphocyte predominant exudate and your TB prevalence is high, then that combination with an ADA over whatever the threshold is in that country, so for us it's 30 international units, then your positive predictive value is 98% for that little constellation, which is great. That is an extremely high positive predictive value, and that could perhaps explain to you why the case that I showed you, I have happily started her on TB treatment for her pleural effusion, even though I have not yet got my culture results back, etc., etc. Now, interferon gamma actually might even be a bit of a better marker. And there are some tests that are starting to become commercially available, but at the moment, still really very few. And most places in the world where people actually are diagnosed with pleural TB don't have an interferon gamma assay available. And of course, each assay has to be validated to have the right cutoff for the right disease in the right place. And so there's a lot of work still to be done to make interferon gamma as well as IP10, for which our group at least has developed a lateral flow assay to make them usable in an everyday clinical context. But the nice thing about these biomarkers is that you can put them onto a little disc as a lateral flow assay. And eventually the idea would be that the clinician can just drop the pleural fluid straight onto it at the bedside, sort of like a urinary lipoarabinomannan that we would do here for disseminated TB. Other biomarkers like the IL-27 are just really investigational. And it is important, again, even though these biomarkers really have very good numbers next to them. And all these numbers are from meta-analyses, by the way. It is important to point out that the same things are have to be considered, in that the studies most commonly lumped in all phenotypes of pleural TB when they were reporting these results. And they very often, most often, used culture or PCR as the gold standard that they were comparing to, which is not quite right. And then I've spoken about the reference ranges and the cutoffs that are not standardized. And they have to be investigated in the region where they're being applied. But here's perhaps a little workaround. We like this very much because doing the LDH, the lactate dehydrogenase to ADA ratio, means that our outside clinics or hospitals don't have to do a couple of more timious and perhaps more expensive investigations like the cell differential count. You don't even have to know if it's lymphocyte predominant to be able to say that it's TB in the context of an LDH to ADA ratio. So there's a few quite good reports from a spectrum of prevalence or TB incidence areas that I'm showing you here. So for example, we've got the report from New Zealand showing that, and of course, New Zealand being a low incidence country, showing that in that context, an LDH to ADA ratio, and I think their cutoff was, now I'm going to speak out of turn, I think it was 12 or something, had a negative predictive value of 99.5% in their setting. Whereas China, which is known to be a high incidence region according to the WHO definition of that, also recently there was a paper which showed a very high overall diagnostic accuracy as well as sensitivity of 93.9%. Very good. And then in South Africa, which I would term an extremely high incidence area with more than 700 cases per 100,000 people every year, we have a positive predictive value of 95% where there is an ADA of less than 10. And the reason why this works so well is because LDH is a marker of your cellular glucose metabolism. And so it goes up in a lot of the main differential diagnoses for pleural TB. So malignant pleural effusions or sort of your hematological malignancy associated pleural effusions are likely to have a much higher LDH than they are to have an ADA, which is what we know the T cells start producing in response to NTB antigen. And so the ratio between the two is a very nice reflection of which type of disease you're dealing with. So lower ratio in most places will mean more likely to be TB, and higher ratio is less likely to be TB. But again, it's one of those things that you have to validate in your own area to know whether it's going to be, what the cutoff is that you should be using. Okay, but how then in Australia or somewhere where there isn't really much data on that, or where you need just a bit more proof to show that this is TB, how do we approach that? And the answer is generally that biopsy is best. Your culture yields and your PCR yields are higher on pleural biopsy tissue. And the other thing about pleural biopsy is that it's not only these microbiologic tests that you're looking at, but it's also just the presence of caseating granulomas. So in somebody that has a pleural fluid ADA that's high, a lymphocyte predominant exudate, and they've got pleural fluid pleural tissue granulomas, caseating granulomas, I mean, there's just a handful of things that can do that. And if you go into the history in an area where there's a low prevalence, you're probably likely to come up with your answer quite quickly. Again, same problem with these data is the lumping in of the different kinds of effusions, but acquiring pleural tissue using what is available to you and optimizing that in your setting is really important. And the reason why I say that is that if you look, and I've just quoted 2 studies there, but really there are quite a few. If you look at the different reports of how well the different types of needles work, how well the different types of imaging works to get your biopsy. They do tend to contradict each other. So in some places they'll say, okay, CT scan guided true cut needle is better than ultrasound guided Abrams needle, or CT scan guided Abrams needle is better than ultrasound guided true cut needle. And it's very difficult to sort through what you're dealing with. But the ultimate message is that whatever center you are in, where you have expertise in that particular method, you should apply that, because you use what you're most comfortable with, you're most likely to get the highest yield. And so that's what I've said here, that the diagnostic yield depends more on your operator familiarity and training than on the technique itself. If you're talking about image-guided closed pleural biopsy with something like a core cutting needle or an Abrams needle. And so there I've got a picture of what we do, which is the ultrasound-guided, and we choose our needle depending on what the pleura looks like, but it's most commonly an Abrams needle because TB doesn't really have big nodules that you can target with the cutting needle. And the nice thing about pleural TB, this is another image from one of our research patients. And what I like about this PET-CT is that it shows you very clearly how the entire pleural surface lights up in the context of pleural involvement. So yes, this is the loculated pleural effusion, and there is definitely pulmonary involvement as well. But if you just look at how bright the entire pleura is, you know that if you're going to sample, if you're going to sample that pleura pretty much anywhere, you're going to come back with some granulomatous inflammation. Now, there is the best option for sampling the pleura is most likely to be medical thoracoscopy in regions where that is available. It's not always available. This paper that I'm referencing there is by Andreas Diakon, also done in our unit and some years ago. And it's very highly cited because in that paper that the medical thoracoscopy had an almost 100% yield for diagnosis of pleural TB, and that was obviously on the basis of histology. Of course, there are caveats to that, but the nice thing about medical thoracoscopy is it is, you know, very minimally invasive. And if you have it, I would suggest that you use it. And this is a few images from some patients with pleural TB showing you that typical, what they call sago pudding nodules and adhesions that is characteristic of TB. This is important for all of you. I know that in many places in the world, interferon gamma release assays are widely available and often used to diagnose latent TB infection, and sometimes incorrectly used to diagnose active TB infection. And I want to just make a few points about why it shouldn't be used to diagnose pleural tuberculosis. Your IGRAs, these are sort of the two main IGRAs that are available. We've got the quantiferon on the left and the T-spot TB on the right. And what they are testing is how much interferon gamma gets made in response to MTB antigens by your CD4 and CD8 T cells. They don't directly test for NTB, which is fine. It's kind of like a biomarker. But they also don't differentiate between the T cell response that's happening because of active ongoing infection or a T cell response that is driven by immune memory. And so you must remember that that means that you might well be getting a response from cells that were exposed to TB 10, 15 years ago, not are currently being exposed to TB. And that's why the data on sensitivity and specificity on IGRAs, pleural fluid, and blood are very low, maximum 80%, and that's very few tests, very few reports that I've read, and it depends on where you are, but here it's probably somewhere in the realm of 60% at most. The theory is that the T cells in pleural TB are already maximally stimulated, so when you stimulate them in the artificial quantiferon environment, they can't make more interferon gamma, And so your null value kind of cancels out any kind of positive signal. Maybe that's true, but I'm not sure. And this is another thing to consider. What I'm showing you here are the results of a study that we've been doing the last couple of years. This is just the IGRA results, the quantiferon results. And you have people walking around in the community. There were about 400 of those people, and we had household contacts who had known recent TB exposure within the last 6 weeks. And we tested them all with quantiferon, and as you can see, somewhere around 75 to 80% of those people in the community and with known TB exposure were quantiferon positive and stayed that way over the 3 months that we followed them up. And so for us to do an IGRA is just a large waste of money. This is my last slide, and then we can go on to some questions, but it's an algorithm that we wrote up for one of the ERS handbooks, I think, a little while back, suggesting how different regions might approach the diagnosis of TB, pleural TB, based on their own local pretest probability of pleural TB for any pleural effusion. So we assume that the entry point is a clinical and radiological suspicion of pleural TB, and then a thoracentesis and perhaps induced sputum if it's necessary. And if you're unable to confirm the actual presence of the organism through either of those methods, then we start taking into account our biomarkers and the local prevalence of TB. And where there is a high local prevalence of TB, we can use that constellation of findings that I spoke about with the lymphocyte predominant effusion, an ADA that's raised, or if you have your ideal cutoff already established, perhaps an interferon gamma, and you can initiate treatment just on that basis. But where you don't have either that constellation of findings, or you have a low prevalence, low pretest probability, and perhaps the ADA is not quite meeting the threshold, then you have to go further. And then we suggest that there is a pleural biopsy through any of the means that I showed you. And that is what I have for you today. We can move on to questions. I should stop sharing.
Excellent. Thank you, Jane. That's very comprehensive. If anybody has got any questions, please type it online for us. But otherwise, I'll start with some of the questions. We often have this debate as to whether the biopsy granuloma needs to be caseated. What is your thought?
We do relatively commonly see non-caseating granulomas. Look, there's a lot of different types of granulomas, the classical granuloma and the non-classicals, and they're not all typically caseating. So for us, we're happy to see non-caseating granulomas, provided the clinical impression overall is consistent with TB. You know, there are a few diseases where the granulomas, non-caseating granulomas might be present and it's not TB. So you have to watch out for sarcoid, you have to watch out for sometimes even some of the sort of T-cell lymphomas and things might give you granuloma. And that's fine. That's why we do biopsies in those situations where it's not completely clear, because with your stains and things, you can do it. But luckily for us, most of the time, it will be caseating.
Yeah. Okay. Now, a couple of questions. Does BCG vaccine has any protection against pleural TB? That's the online question.
You know, I don't have a direct answer to that. I don't think it's ever been looked at. The BCG vaccine is great for protecting against severe forms of TB. And in that, we're talking about TB meningitis and disseminated TB. And we know that by the time somebody reaches adolescence, the protection kind of wears off.
Yeah.
Pleural TB is one of those forms, even though it's extrapulmonary, it's not generally considered to be a severe form of TB. And so it probably doesn't have the same level of protection from BCG vaccination as the other form. So I'd say probably it doesn't
Sure.
do much.
So another question, well, that's a lot more questions today. Another question is, do you have a diagnostic dilemma when you have a neutrophilic effusions with a high ADA?
Yes, but generally that is sorted out at the level of your clinical impression. Because, so when you've got a neutrophil predominant effusion, you're probably, you know it's probably an infection, right? And so it's just sorting out which organism it is. And in somebody who's got a bacterial infection, they're septic, they're sick. It's a totally different person, a totally different patient from the one that's presenting with a TB effusion. Yes, occasionally they are septic and they may well have you know, some symptoms, but the acuteness of the presentation is often quite different. And the other associated features are also quite different. So there should be a pneumonia associated with kind of normal consolidation if it's a bacterial infection, whereas when you've got a TB infection, your imaging is going to show somewhat different pictures. So we tend to sort it out at that level. We don't always find an organism, which I think is sort of the same everywhere. And yes, some of the times we do a biopsy just to find the organism as well, even in just general bacterial infection. But you always cover your patient with antibiotics in that situation anyway, you know, so according to your antibiogram. And a lot of the time we infer from treatment response as well.
Yeah. And
so
I think
yes.
it would be fair to say that although I know the book says that neutrophilic TB pleural effusion does exist, it exists in a very, very small percentage of all the TB pleural effusions. And I think you need to be very, very careful to call something heavily neutrophilic as to be a pleural effusion.
Yes. And, you know, I wish I could confidently say what the prevalence is of the neutrophil predominant effusions and TB empyema specifically. But my practice is heavily biased in that we see more of those cases because they come for biopsy and they come for, you know, additional workup. And so we see a lot of TB empyema, but that's not, that's definitely not the commonest presentation by a long way.
Yeah. Someone from Malaysia, the question is LDH over ADA ratio. Do you think that is likely to be incorporated in future decision guidelines? And often if the patient is not fit for thoracoscopy, they're looking at just doing this and then closely following up with chest x-rays. And what's your thoughts?
I'm very pro LDH to ADA ratio, and I think there is a reasonable amount of data now to be looked at more carefully. And I sort of vaguely remember a meta-analysis sometime recently, but I'm not confident about that either. We're hoping to create a guideline along with the ERS over the next couple of years, in which case we will do a very rigorous look at that data and decide whether it should be incorporated into the guidelines. My feeling is probably it will be. And in terms of follow-up, yeah, radiology is one way you can follow them up. The problem with that is the fluid often takes a long time to resolve. We find the patients feel better very quickly as well, which is often an issue with getting them to carry on taking their treatment. So really, a lot of the time, you just have to forge ahead with the treatment regardless.
Two questions related to biopsies. One is, what is your personal preference of biopsy needles? And number two is that if they only got small amounts of pleural tissue samples, would you prefer to send it for culture, or would you prefer to send it for gene expert ultra?
Ooh, yeah, tricky.
Okay, I think
so
the answer is to get more tissue, right?
Yes. Yeah, no, what are you doing sending one sample? No, so my personal preference is the Abrams needle, but that's, you asked for a personal preference. That's why I like the feedback that the needle gives you, where you can feel you actually get the tactile sensation of taking the bite of the pleura and taking it off. I also like the slightly wider chunks that it gives you, whereas the core cutting needles give you much longer and narrower chunks. Again, it is a personal thing. And I often feel like the core cutting needles, where you have the thin, uniformly thin pleura, like you do generally in TB effusions, your cutting needle sometimes just scrapes along the top. Whereas the Abrams is more likely to get a deeper sample.
I was going to say that I'm old, but Jane is not old, but I'm old and I'm very used to Abrahams, and we still use that quite a lot in this kind of setting. Next question was, does the MDR-TB, sorry, Jane, does the MDR-TB, there's quite a lot of questions, I'm trying to get through as many of those. Does the MDR-TB, does any of the biochemical tests behave differently from the fully sensitive TB?
I don't know. I don't think there's enough data really to answer it. The MDRs, they tend to be a bit sicker with more advanced disease. And so you more often have parenchymal involvement. That's the one feature that's likely to be different. But just pure pleural effusion, that's MDR, you almost never see that. Partly because you almost never see positive culture results. But as far as I can tell, the chemistry is roughly the same.
Yeah.
Yeah.
So another question was that because LDH is always high in exudate, why don't we just use the LDH? Why do we need to adapt the LDH to ADA ratio?
Well, the ADA is the TB specific part of that, where the LDH is a generic thing, like, you know, in any effusion that's got high cell turnover, particularly malignant effusions where there's lots of cells consuming lots of glucose all the time, you're going to have a high LDH. That's why it's having it in relationship to the more TB specific ADA is such a robust marker. So your ADA being higher, camera's reversed, it's the wrong hand. The ADA being higher and your LDH being lower is what increases your likelihood that it's TB, whereas the other way around is going to be malignant effusions, lymphomas, etc.
And one other question was, do you ever use TPA DNAs in these TB effusion patients?
Well, we can't afford DNAs. And a lot of the time we can't afford TPA either, but I don't want to say that this is in any way the right thing to do because we don't have enough data to prove that it is, but we use what we have available and we seem to get reasonable results. I've seen good results just with streptokinase and single agent TPA. I know you do need the DNAs to prime it, but we get reasonable results. We also don't get bad results just from saline irrigation, you know, but then that's quite labor intensive. So you have to have them admitted in your ward, my own ward, so that we can go and sit there every day and pour the saline in and out. Yeah, so there are definitely options. And interestingly, when you look back at the data on the TPA and DNAs and a few of the other intrapleural fibrinolytics, a lot of them actually did include TB effusions as part of their population. So it is mixed in there and all of that data together is sort of very positive for the use in pleural infection. So I think there is a role for it. And again, we're hoping to incorporate that in guidelines coming up.
Okay. Well, given how popular this talk is so far, we'll probably need to invite you back and talk about the treatment side of the TB pleural effusion, TB empyema. We didn't have time for that, but we'll save it for next time. And thank you for everybody who has joined us today. We're quite a bit over time, so we're going to stop here. And once again, if you want to watch it, if you missed it, go to YouTube and just look at TAPS Pleural series. And next month, again, every first Wednesday at the same time, we will have the next talk. And next time we have Judith Chadler from New York to talk about fibrinolytics in pleural effusion, another topic that is likely to generate a lot of discussions. So thank you, Jane, again for joining us, and thank you for everybody who has joined us online. We'll see you next month. Thank you.
Thanks for having me. Bye.